Greater occipital nerve block is a valuable tool in the treatment of cervicogenic headache and occipital neuralgia. Greater occipital nerve block is a local block directed 1/3 the distance between the occipital protuberance and the mastoid process. We feel the evidence best supports its use in the treatment of cervicogenic headache and the closely related occipital neuralgia. More than half of patients experience relief from the local injection. Some studies suggest that patients with pain over the occipital notch upon palpation will most benefit from injection. However, our review does not suggest this as a necessary indication for block. Cervicogenic headache typically begins in the neck or occipital area and is one-sided. Often the pain can be triggered by neck movement, sustained abnormal head postures, or by pressure over the occipital nerves or upper cervical vertebra and nerve roots. The nature of the pain is moderate to severe with non-throbbing, deep, achy pain that has discrete episodes or a fluctuating continuous course. The patient usually has limits in range of neck motion and stiffness. There is often a history of whiplash injury. The patient may have nausea, dizziness, or blurred vision, so it can sometimes be difficult to distinguish from migraine headache. Occipital neuralgia is characterized by pain occurring in the distribution of the greater or lesser occipital nerves. The pain is typically burning or sharp and shooting. Paresthesias and numbness over the occipital scalp are often present. Greater occipital nerve block can be chosen as a first-line therapy or after a traditional medication regimen has not provided adequate relief. Contraindications to greater occipital nerve block include posterior fossa intracranial surgery, recent trauma to the area, and allergy to lidocaine or bupivacaine. The most commonly reported side effects include dizziness, pain at the injection site, or vasovagal or syncopal events. Rarely, focal alopecia, hypertension, flushing, and prolonged hyposthesia have been reported. The close proximity of the occipital artery, typically just lateral to the occipital nerve, helps in locating the appropriate location for injection, but is therefore also at risk for puncture and hematoma. Use a combination of lidocaine and bupivacaine for anesthesia. Onset of action for lidocaine is about 2 minutes and lasts 2 hours without epinephrine and 3 hours with epinephrine. Onset of action of bupivacaine is about 5 minutes and effect lasts 4 to 8 hours. The length of relief from a nerve block is often not related to the duration of action of the blocking agents, but can last much longer. Additionally, greater occipital nerve block can at times help relieve pain in other branches from the C2 nerve root. Here are the supplies you will need: an alcohol swab or chloroprep for cleaning, an 18-gauge needle for drawing up and a 25-gauge for injection, a 5 cc syringe, 1.5 milliliters of 0.5% bupivacaine, 1.5 milliliters of 1 or 2% lidocaine with or without epinephrine, skin marking pen, and a Doppler to help identify the occipital artery. With your 5 cc syringe, an 18-gauge needle, draw up 1.5 milliliters of 1 or 2% lidocaine. We are using without epinephrine here, although both can be used. Additionally, in the same syringe, draw up 1.5 mL of 0.5% bupivacaine for a total of 3 mL. Now place your 25-gauge syringe on the end. Have the patient lie prone on the bed or with the patient sitting in a chair, leaning forward with their forehead resting on the stretcher. Key landmarks include the occipital protuberance and the mastoid process. Imagine a line extending between these 2 points, also known as the superior nuchal line. Starting at the occiput, the artery can be palpated at approximately 1/3 the distance as you move toward the mastoid. This is where the Doppler can be particularly useful to help us pinpoint the artery and get a better localization of the greater occipital nerve, which is typically found just medial to the artery. Once the desired area is located, mark the area with your skin marking pen or your fingernail and remove the Doppler. Clean the area with alcohol preps, allowing to fully dry. Insert the needle 90 degrees to the skin surface at the previously marked area, pulling back on the syringe to ensure you are not in the occipital artery or other vessel. Insert the needle until you feel a bony protuberance and inject 1 milliliter. Fan the remainder of the anesthetic around this area without removing your needle from the skin and aspirating on the syringe prior to injection every time. Remove the needle and with a piece of gauze, massage the area in gentle circular motions to help spread the anesthetic and, at the same time, holding pressure to mitigate any bleeding. You may decide to repeat this on the opposite side depending on the patient's presentation and pattern of pain. Monitor the patient for the next 15 to 20 minutes for any side effects. While many patients have relief within this time frame, many may have relief over the next few days. So be sure to convey appropriate expectations about the potential range of effects prior to doing the procedure. Considering the ease of the greater occipital nerve block, the paucity of side effects, and the frequency with which patients present to the emergency department complaining of headache, it's about 2.5% of all emergency department visits, we recommend being comfortable with this technique.